Well, good morning to everyone. I'm Dr. Shannon Zank. I'm the director of the National Institute of Nursing Research, and I am so pleased to welcome you all to NINR's Director's Lecture on Prevention and Health Promotion. Today's event is the fourth in a series of webinars that we're hosting to provide an in-depth look at each of the research lenses in our new 2022-2026 strategic plan, which we launched in May of last year. Next slide, please. So first, I'd like to remind everyone that today's lecture will be recorded and made available through our website, ninr.nih.gov. Closed captions are available and may be enabled at the bottom of your screen. Next slide, please. Before we get started, though, with today's lecture, I want to acknowledge that May is National Nurses Month. This year's theme is You Make a Difference. Nursing is the largest and most trusted health profession in the country. Nurses interact closely with individuals and families across a wide variety of settings. In hospitals and clinics, in schools and workplaces, in homes and justice settings, and in communities across the globe, from urban to suburban to rural. This makes us the backbone of the health system, and it's clear that we truly make a difference in the lives of individuals and entire communities. I want to thank all the nurses joining us here today for everything that you do. Next slide, please. So now I'll begin today's webinar in earnest by telling you a little bit about NINR's strategic plan. At NINR, we are committed to leading nursing science to solve pressing health challenges and inform practice and policy, optimizing health and advancing health equity into the future. Our mission statement reflects our belief that nursing research is the key to unlocking the power and potential of nursing. And our strategic plan describes how we want to leverage the strengths and unique knowledge and perspectives inherent to the discipline to the benefit of all people. Next slide, please. The plan includes 5 research lenses that we think will help push nursing science to innovate, think bigger, and greatly increase our impact. So when we say lens, we're describing a perspective through which to examine a health challenge. The lenses in the strategic plan are health equity, social determinants of health, prevention and health promotion, population and community health, and systems and models of care. Next slide, please. Today's webinar will focus on our research lens, which aims to prevent disease and promote health through the continuum of prevention. From NINR's perspective, prevention refers to actions taken to reduce the risk of disease, disability, or injury along a continuum from primordial, which targets underlying risks, to tertiary, which aims to reduce progression or severity of symptoms. We are interested in supporting nursing research that identifies the mechanisms through which interventions work. Moreover, prevention and health promotion efforts must aim to eliminate health inequities by accounting for the myriad factors that affect risk. Next slide, please. So through this webinar series, we aim to help nursing researchers better understand and apply NINR's research lenses to their own work. We have 3 learning objectives for this series. First, we want to provide a forum for discussion on how nursing research can help address our nation's most pressing health challenges. Second, we want to provide examples that illustrate the possibilities for scientific inquiry through NINR's research lenses. And third, we want to discuss practice and policy implications of nursing research through each of the lenses. So you can use the Q&A module to ask questions at any time during the webinar. We will hold questions until the end and try to get through as many as we can. We are also very pleased to offer continuing education credits for the webinar today, so do stay with us until the end for more information and a QR code to scan to obtain credits. Next slide, please. So I am just delighted that we have two distinguished speakers with us today to talk more about research through the prevention and health promotion lens and the implications for policy and practice. In the interest of time, I will give brief introductions, and more complete bios are available on our website. So our first speaker is Dr. LaRon Nelson. He is the Independence Foundation Associate Professor and Associate Dean for Global Affairs and Planetary Health at the Yale School of Nursing. He also serves as the Director of the Justice, Community Capacity, and Equity Core in the Center for Interdisciplinary Research and AIDS at the Yale School of Public Health. His work in health and HIV disparities is concerned with developing and testing interventions that address the social, structural, behavioral, and clinical influences on HIV prevention and treatment. Our second speaker is Dr. Debra Furr-Holden. She is the Dean of the New York University School of Global Public Health and Professor of Epidemiology. She has broad expertise in health disparities and policy-level interventions to promote health equity. She is an epidemiologist with expertise in drug and alcohol dependence epidemiology, prevention science, and environmental strategies and structural interventions for violence, alcohol, tobacco, and other drugs. So Drs. Nelson and Furr-Holden, welcome. We are so pleased to have you with us today. And with that, Dr. Nelson, I'll turn things over to you to get us started.
Thank you, Dr. Zink. It's my pleasure to be here. Let me just figure out how to do this here. I hope everybody can see the proper screen. The title of my talk today is An Ounce of Prevention, but Pound of Problems, matching health promotion to the scale and complexity of health risk. So I'll start.
Nelson, I don't see your screen yet.
Okay, let's try that again. How about now?
Perfect, thank you.
Okay. Thank you again. The title of this is An Ounce of Prevention, but Pounds of Problems. I want to start by just reflecting on the history of prevention and health promotion. In nursing science in particular, we have a very long history of achieving prevention outcomes through the use of health promotion interventions. The mechanisms by which these interventions have generally worked is by identifying and influencing behavioral antecedents. So these are what scientists have understood to be what lead to a particular behavior in a given situation. And it's what we hypothesize will increase the likelihood of a desired behavior or desired pro-health behavior in any given situation. So a great deal of that science has strong theoretical foundations, such as the health belief model and the information, motivation, and behavioral skills model. As an example of this, the photo you see on the right side of your screen is an example of a successful health promotion intervention called Hip Teens. The evidence of this efficacy was established through an NINR-sponsored randomized controlled trial that was led by Dr. Diane Morrison-Beatty. It was also based on the information, motivation, and behavioral skills model. Now, I know a lot about this intervention because I was a research assistant on it as part of my PhD training at the University of Rochester. And what I know about it is that as a result of this intervention, the young women who participated, the teen girls who participated in the intervention had fewer episodes of sex, fewer sexual partners, fewer episodes of condomless sex, and fewer unplanned pregnancy compared to the young girls who were in the control group. Now, there was also recognition and continuing recognition of others that others in your social environment also have an influence on an individual's behavior. And health promotion interventions began to incorporate important others like families, friends, sexual partners, and other individuals in order to optimize the prevention impact of health promotion interventions. Now, the logic of these behavioral approaches that we had available at the time were really steered by our beliefs in the possibilities of what could change. These are sort of have grouped themselves into two categories that you see here. That is modifiable factors, things we can change, such as knowledge, attitudes, beliefs, behavioral skills, and then non-modifiable factors, things that we believe we cannot change, social status, income, race, gender, so on and so forth. But having worked in health promotion work as a trainee and as an early investigator, I began to understand more and more that these non-modifiable factors, maybe I should say so-called non-modifiable factors, were shaping the degree to which health promotion could actually have a population level prevention impact, because they limited the amount of gains that can be achieved, could be achieved, and can be achieved. And so I'll describe two overlapping components that I think influence this phenomenon. First are political determinants of health. Political determinants of health are sort of a short definition, policies and processes that outline a structure of the opportunities or limits for a healthy life. So this can be influenced by, as an example, do you live in a county that has expanded access to insurance coverage? If you do, that might lead to more healthy living. And if you don't, that could be some challenges. Do you live in a place where interactions with police systems can abridge your rights? Your right to be able to work, your ability to have safe housing or housing at all, your ability to vote, which could be a metric of perceived control over your life if you don't have a say in your governance. Or, are you in a place or an environment that has some impact on the degree to which you can exercise self-governance over medical decisions versus, how would I say it? Versus being able to exercise self-determination over your life. If you live in a place that imposes sort of legal constraints over how you can live, how you can govern your body, right? Those are political determinants. Those are things that outline what are possible for us in our communities. This relates very closely to social determinants, and social determinants are the conditions in these environments where people live that influence health and illness. The political determinants are the outlines and create the parameters for what is possible in a social context, in a social sense. So this could be housing. If you have poor quality housing, that's going to undermine asthma prevention goals. If you live in places that have poor ventilation or pollution, whether that's directly in the house or if you're living in a place that is near a highway or places, factories that put pollutants into the air that children have to inhale and breathe, that will aggravate asthma symptoms. Unemployment we know is associated with increased stress. Increased stress is associated with impaired immune function. We know financial crises also are stressors that we've seen lead to mental health issues such as higher rates of addiction, depression, and suicide. And even things like incarceration history, which even my own work has shown is associated with increased risk of exposure to HIV. Mostly, probably, we think through the way it structures post-incarceration life that lead people to engage in behaviors in some ways for survival, or that limit the potential stability of romantic sexual partnerships. So these social and political determinants form a structure that does more than just sort of sit there. It is a system that organizes every aspect of American life. The work that you do, the life that you live, where you work, what you study, what your children do, all of this is still subject to this system. And we know what this is because we acknowledge the presence of these determinants, if you will, in our study populations. Everybody has in their publications a table 1 that lists the descriptors of the demographics of the sample. But these table 1 descriptors don't just simply describe the sample. They actually show the distribution of where people fall within this social hierarchy. We don't always understand that that's what it is describing, but that is essentially what it's describing. And we can see it more clearly when we compare groups. We start doing that. We look at men versus women, or transgender people compared to cisgender people, white people compared to Black people, citizens compared to immigrants without permanent status. And we see those differences. But what we are seeing are how our society distributes certain important determinants, such as risk versus protection, punishment versus impunity, how we distribute privilege or oppression, and urgency versus apathy. And I use distribute deliberately because it's not a passive process. And I don't think we often give attention to the function of these determinants. It is an active process. It is distributed because these either benefits or restrictions are given to people based on their privileged status. Constraints on self-governance are distributed to women, and men don't have to deal with that to the same rate. The social process allows that to happen. What this does is, or how this is enacted, is through what Paul Farmer has termed structural violence. And structural violence is the overexposure, how these systems overexpose us to risk and to illness. So it's not just all around us or just in the background, it's working. We can't simply treat these things as variables to be described. They have to be counteracted. So I want to make sure you get what I'm trying to say here. So I'm going to offer a dramatic example from a documentary. This is a documentary called Trouble the Water. It's focused on Hurricane Katrina. It was in New Orleans in 2005. And it takes excerpts from sort of a lay citizens chronicling of how that event unfolded. Let me just make sure one thing here. Okay. Are you seeing the screen? I hope so.
Not quite yet.
Okay.
We're seeing your presenter view now, if you can switch the view.
Thank you. So what you'll see here is, and here are calls to a 911 operator from people who are experiencing this disaster.
Operator 165. We have water halfway in our house and we are in the attic. Okay, ma'am, at this time, there is no rescue team. We don't have no ladders.
Sir, there's no emergency units available at this time.
You gotta be serious, man. Please, 8-year-old bed and they live 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12 children, little bitty children. At this time, they're not rescuing.
Sir, at this time, there's no available units for emergencies at this time.
The water is steady rising in the attic, ma'am. I'm a child in the attic.
Can you break a hole in the attic?
I tried. I broke a chair part. I cannot pry this wood off this attic, ma'am.
So the police is not coming out until the weather conditions get better.
So I'm gonna die. Hello?
Yeah.
I can't get out.
So again, structural violence is enacted through how it overexposes us to risk and to illness. The health problems, the reason I show this example, because I think people can get it when they can see it and hear it and feel it in ways that I don't think we often can get it if we're just thinking about it. The health problems that our nation faces are treacherous. They are growing in scale. Their devastation is extraordinary. This includes diabetes, cancer, hypertension, COVID-19, monkeypox, HIV, you name it. These are the storms, and they are still raging. And if health promotion is our levee system, we need to redesign it because some of our systems are not fully equipped to match the threat that our populations face. We must take into account that the social and political determinants that influence people's lives are going to have an impact on whether or not prevention is experienced at scale. If we don't do this, then our innovations in health promotion and prevention will meet with these conditions that will distribute the benefits to privileged groups and constrain the prevention impact on marginalized and minoritized groups. So in HIV, I will tell you, the levee has burst. We are underwater, and Black communities and increasingly Latino communities are drowning in this HIV epidemic. This slide you see shows trends in HIV incidence among men who have sex with men, with comparisons between white and Black MSM over a 10-year period. It maps onto this timeline the introduction of innovations such as treatment as prevention, which we know through HPTN 052, the introduction of pre-exposure prophylaxis, this is oral pre-exposure prophylaxis, and HIV self-testing. And so when these innovations came onto the scene, the health promotion world got busy doing what we do best, and that is increasing knowledge, improving people's attitudes about these products, their beliefs about their efficacy, and enhancing their behavioral skills to use these products. And what did we see? I guess in some ways we saw what we expected to see, which were dramatic decreases in HIV incidence over this 10-year period, but for white MSM, and almost no change for Black MSM. And why is that? Why did we see a change in white MSM and not see a change over a decade in Black MSM? I propose to you that it's because our health promotion approaches have not sufficiently met the task of simultaneously influencing the conditions in which many Black MSM live. The innovations change, the conditions did not change. So what you see in this situation is the Black MSM cannot pry the wood off of the attic. That's what we're asking them to do, asking them who are trapped in these social structures that are constraining their ability to take advantage of health promotion and prevention products and saying, pry the wood off the attic. Or, and at least in this example, they cannot pry the bricks out of this wall, this social determinants of health wall that is in the way. So our health promotion must evolve to be able to meet these challenges. It can't just be knowledge, attitudes, behaviors, and beliefs. We have to think towards multi-level integrated strategies that we can combine that we think will also have an impact on the conditions of people's lives in ways that will optimize prevention. What I'll do for the next few minutes is talk to you about a couple studies that I've been involved in that have tried to do this, and also try to sort of highlight for you the way in which I think NINR is going to help us address these issues that we haven't done as a scientific community for decades. First study I'll tell you about is a study from the HIV Prevention Trials Network, HPTN 073. This is this tagline, my life, my health, my choice. The focus of it was to understand whether or not if we provided autonomy support through healthcare facilities, could we increase rates of PrEP initiation and adherence among Black MSM? So this was theory-driven. We use self-determination theory as an approach for it. The main components of that were to increase autonomy, the degree to which the men felt free to be themselves, to disclose, to understand what the risk and possibilities were for PrEP in healthcare facilities, which meant the facilities had to change. So we spent a lot of time working with the facilities around how to create an environment that was autonomy supportive. The second part of that was how to increase their competence. So this competence is different from, say, self-efficacy, which is, in a nutshell, do you think you can do it? Competence is, you want to do something, but can you accomplish it? And what are those barriers in the way that prevent someone from accomplishing it? Those barriers can also be profound, but that the healthcare facility, people who work in it, have a stake in helping folks overcome these barriers to reaching their prevention goals. That is competence. And then relatedness, which really is showing that the people who are supposed to be providing services to you are care about you as an individual, not just as a service number, if you will. One of the papers we published from that was one that examined the health promotion pathway from autonomy support to health behavior. So we hypothesized that autonomy supportive environments would increase people's Black MSM's ability to have more autonomous self-regulation around PrEP, and to really increase their perceived confidence that things could be in place that could help them actually achieve the goal of initiating PrEP and adhering to PrEP. The health behavior in this model was PrEP adherence, which we used a measure of therapeutic serum levels of PrEP in the blood, and that was by using dry blood spots that were taken from the men. So using this and conducting a structural equation model, we found that this pathway was significant. The data matched it, that autonomy support led to what you see in the middle with basic need satisfaction for PrEP use. Those basic needs are the ability to autonomously self-regulate and also to feel like you can actually accomplish PrEP adherence goals despite what barriers might come in the way. And that those led to therapeutic PrEP levels among the men that we sampled at 6 months. And this model actually accounted for 52% of the variance in serum PrEP levels among Black MSM. We also looked at the effects of coordination quality on autonomy support. Some of the needs that the men have are outside the scope of what the clinic can provide. So we were very interested to understand the pathway between autonomy support, setting a PrEP adherence goal, making progress towards that goal, and being able to adhere to PrEP. But above and beyond that, we were interested to understand whether or not coordination quality had an effect on that pathway. So we test whether or not it moderated. And what we did find is that quality care coordination enhanced the association between setting a goal and progressing towards that goal. And that coordination quality also enhanced the association between making prevention goal progress and PrEP adherence. So coordination quality is, to what degree is this system helping me manage these other aspects of my life that impact on my health behavior and decision makings? That was important, and we demonstrated that in that HPTN study. The next example I'll tell you about is from a study I recently completed with Dr. Nora Nyblade at RTI International. This is a NINR sponsored study titled Promoting Reductions in Intersectional Stigma Among MSM. So in Ghana, stigma is a barrier to healthcare seeking among gay and bisexual men and other men who have sex with men. This table just shows you that these stigma manifestations occur across multiple levels: community, institution, peers, and family. And so our health promotion intervention had to be designed in a way that met that multi-level complexity. So that's what we tried to do. We put together 3 different interventions. One that is at the healthcare facility level, which is HP+, the intervention that Dr. Nyblade led, and then one intervention that is at the group level, called Nyantapo, which is an adaptation of Many Men, Many Voices, and Hive 3, which is a peer support component. What we did is try to reduce intersectional stigma reduction at the healthcare facility level and through Nyantapo and Hive 3 at the group level and at the intrapersonal level, because some of the stigma becomes internalized. Then we structured so that these people could come together. We would have the men in the intervention group attend facilities that got the HP plus intervention. And by doing that, could we increase healthcare visits, healthcare behavior seeking, and increase the frequency of testing? What we found is that we had significant reductions in intersectional stigma among healthcare staff in the facility. What you see here is that for some reason, the intervention facilities had higher stigma at baseline than the control facilities. I'm not sure how that happened. They were randomized, but this is what we have. But we did see a sharper reduction in stigma in the intervention group compared to the control group in the facilities at 3 months. And at 6 months, the stigma continued to decrease in the intervention group, but not a significant difference between the intervention and control at the 6-month time point. We also looked specifically at a subscale of the intersectional stigma, which focused on gender and sexual norms. How do the healthcare facility staff see or understand men who come in who don't act the way they think men should act? You know, they don't conform to gender norms, and their sexual behavior are outside of what they consider or perceive to be norms within that particular cultural context. So again, in this study, the intervention facilities had higher gender and sexual norm stigma at baseline, but significantly reduced that compared to the control facilities at 3 months and continued to reduce at 6 months. So at both time points, gender and sexual norms stigma was lower in the intervention group compared to the control group, which is important as we understand what needs to happen in these facilities. So the other goal was, could we get men to go to these places, to go to intervention facilities? And what I'll show you now is that we did a comparison of men who said that when people look at me, they consider me to be feminine, compared to those who say people don't consider me to be feminine. And what we found is that at baseline, men who said folks see them as feminine, only 20% of them visited healthcare facilities at baseline. That's what they reported, compared to about 40% of those who said people don't consider them feminine. Maybe we'll just call them masculine men. But that over the 6-month period, the percent of feminine men who attended healthcare facilities tripled from about 18% to 55%, whereas the percentage among men who considered themselves masculine didn't change at all. This was a significant difference. But this also shows the power of this multi-level health promotion, because it would not have been enough for us to try to convince these guys to go to a clinic where they would have been stigmatized. We had to simultaneously work with the men and with the clinics to improve the health promotion and get some prevention effect. And the last thing I'll say on this study is we looked at whether or not there were increases in HIV testing. And we saw that the main increases were in HIV testing at intervention facilities. That men who went to intervention facilities had higher frequency of testing, both at 3 months and 6 months. They had higher odds of HIV testing at 3 months, 6 times higher odds, and almost 10 times higher odds of HIV testing at 6 months. The last study I reviewed you is one that is currently in the field. This study is supported by the National Institute of Allergy and Infectious Diseases, the National Institute of Mental Health, and with support from the Centers for Disease Control and Prevention, HPTN 096, a study I co-lead with Chris Byer at Duke University and Bob Remian, who's at Columbia University. So again, this study uses a multi-level integrated strategy, which combines interventions that address multiple challenges. Of course, the behavioral challenges, but also the social and structural challenges, which are not typically what you see in health promotion work. So the center of that is trying to leverage what we know about testing, the efficacy of ART, and the efficacy of PrEP, but also addressing those things around it with structural and social behavior determinants that we know might undermine the impact of this for Black MSM. This just shows how the multi-level integrated strategy works. Health equity is the overarching foundation for this. Is really trying to figure out how to address those barriers to getting access to PrEP and treatment in facilities. We have peer support, which addresses some of the internal interpersonal issues that men might need support on, emotional support, informational support, things to be more affirming. Social media is designed to create different social norms that support PrEP use and treatment, that reduce stigma, but also that steer men to these clinics where we're going to be having this culturally responsive stigma reduction intervention. And then if we can do that, we hypothesize that we'll have increased number of men who actually seek services in clinics. We'll have increased number of men who are on PrEP and thus protected from HIV infection if they're exposed, and increased rates in viral suppression among Black MSM.
Hi, Dr. Nelson, just a really friendly 1-minute warning. Thank you so much.
Thank you. We have, this is a 4-year study at this point. We started ramping up. The intervention will go for 2 years and we'll have data hopefully by the end of 2026. The outcomes we're looking at are viral suppression, PrEP uptake, and number of Black MSM patients in communities. These are the cities where we'll be: Dallas, Memphis, Montgomery, Fort Lauderdale, and Atlanta. We've already started working Dallas, Montgomery, and Fort Lauderdale. So this is a multi-site trial that we're testing. And then how I'll end is, this is a picture of Thomas Kuhn, who I learned about also in my PhD program. And he talked about the structure of scientific revolutions. And I show this because part of his model about how these revolutions occur, I do think we've reached a crisis, scientific crisis in health promotion and prevention, that we have to figure out different ways to do this work because the current interventions we have and our current approaches are not matched with the complexity of the problems. And this is where I think NINR is leading the way. I think it is leading this revolution because this new strategic plan that it has and these lenses addresses just that. I think it's bold. I think it is ambitious. And I think it's what we need, because if not, I think we'll still have nice, efficacious interventions, but very little impact and not as much equitable impact as we could and should have for communities. Thank you.
Dr. Nelson, thank you so much. What a great presentation. And I'd like to transition to Dr. Furr-Holden to share her perspectives with us. Thank you.
Great, thank you so much. I am going to do my very best to cover a lot of ground in a very short period of time. So I will let folks know I'm a big fan of the QR code because I'm going to put up and spotlight some research that I've done and that others have done that speak to some of the points that I'm going to make, because we're not going to be able to deep dive. I've already glanced at the questions, but I think maybe in the Q&A we can unpack, 1 or 2 things if you find them really important, but, have your phones out because I got QR codes. So I really think Dr. Nelson did a great job at sort of framing out some of the problems in a big sense and then giving us some specific examples, even out of his own research. And I love this analogy of the wood in the attic and being trapped in the attic. So I'm going to talk a bit about, through this sort of prevention and equity sort of anchored lens, what are some of the solutions? And I'll highlight a few examples along the way. So one of the things is I think it's really important that we lead with the science. And science is based on hypotheses, not agendas. And unfortunately, what we find oftentimes is the agenda is what's carrying the day. People start off sort of already knowing where they want to go, and then they just keep throwing the statistical fishing rod in the data until they get there. I think this is a really, really important point that we have to make. One of the things, I was in Flint, Michigan before I came to be the dean at NYU Global Public Health, and I watched my colleagues get into this nasty debate over whether or not the Flint water crisis even existed. And it was funny because it actually played out in the newspaper and it played out a little bit in some scientific articles where people literally started using different methods to try to discount the fact that we had even had a crisis. So I just think it's really important that we stay true to our work and our disciplines and lead with the science and well-founded hypotheses. Also included in that is we need to provide valid frameworks. I won't go back through this because I've seen other speakers have done this and Dr. Nelson did. And I love it when he talked about both the social and political determinants of health. The one thing I'll point to is just imagine that these boxes are resources. People show up differentially prepared and differentially resourced. If we deal with the systematic and structural barriers like the fence and simply go from a wood fence to a chain link fence, notice those boxes are not even needed. And it doesn't matter how tall you are when you got to the game, you're protected from the balls rolling over, and those resources get to be used in other ways. The reason that I think this is so important and these frameworks and how we frame it matters is because resources need to go to solve other problems. If we can deal with systems and structures instead of trying to program our way through things, programs cost a lot of money and they're important. And there are some things that is our only pathway. But dealing with these systems and structures, I think, offers us great promise as well. I've been working with some colleagues on a model that we've created around what we call eradicate racism. It's bringing a public health approach combined with the truth, racial healing, and transformation work started by Gail Christopher and the Kellogg Foundation. It's very related to the work that was done out of the truth and reconciliation work that spawned in South Africa. And we're developing it. We're developing an empirical model that actually has sort of a guide and framework and evidence underneath why these pieces and why these things work. So we need these kinds of really valid and potent frameworks. We've also got to grapple with the tough conversations and have an authentic reckoning with the past. I saw one of the questions in the chat from somebody who's a student in Florida, making a note that Florida has been enacting many laws that are very racist in nature, or that create barriers for potentially either the student doing the kind of work they want to do, or the faculty at the university being able to support the student doing that kind of work. We've got to stand in the face of that. So I had to delete some slides for time, but one of the things that I always say to people is, you have power in your vote. If you really don't want to be in a place or be under the kind of law that literally suppresses the kind of scholarship that you want to do or what you know is wanted and needed in the world, then you've got to exercise that vote, because without this authentic reckoning, we become victims again of our past, and that history repeats itself. I think we should boldly be able to confront that past and then create these more innovative, timely, human justice-centered models for how we both train people and solve problems. I always like to throw this tidbit in with this reckoning. Poverty is not an equal opportunity experience. There's this tremendous overlap between race and poverty. What this shows us is we've basically made zero progress in Black children living in poverty since 1974. We have about the same percentage of Black children living in poverty now as we did in 1974. And you can see for all other groups, we've made progress in those areas, even cutting the percentage almost in some cases in half. Here's another great example. If you were living in poverty for at least 1 year as a child, you were ever poor for at least 1 year as a child, if you're Black, you have almost the exact same likelihood of living in poverty in your 30s. If you're white, about 50% of white kids will move out of poverty. So there's something about being Black, I call it the Black tax, that contributes to this persistent and intergenerational poverty. I don't think it's individual, I think it's structural. We've got to be able to talk about things like this and figure out, what does that mean in my research? What does that mean in how we create and design programs? What does that mean in how we create policy and make sure that policy is both implemented and enforced? Because clearly the things that we've done as a country to lift children out of poverty have worked, just not for Black and brown children. Plug the leaky pipeline. As an academic and a scholar and now a dean, I feel like we have these very perverse incentives for performance. The leaky pipeline comes out of the dissemination and implementation science literature. It's called the 17-year Odyssey, which basically says it takes on average about 17 years for only 14% of research to ever be translated into practice. And I know as a group of nurses and nurse researchers, the numbers might be slightly better for you all, but how do we have the innovation and what comes out of research and also practice, not just simply live in some, manual or at a conference or in a peer-reviewed journal? And then how do we have practice-informed research, where it's not just a one-way pathway, because oftentimes research can be very disconnected from what's happening on the ground floor. So it's also about building this sort of, interdisciplinary, but also cyclical, process where one is fueling the other and vice versa. It can be multi-directional. And we've got to confront the fact that if people want to produce a kind of scholarship like Dr. Nelson is talking about, this is not like fast food scholarship. This is not stuff that's going to get produced overnight. And it's also not the kind of stuff that is necessarily the most popular when we talk about the realities of what many academics have to go through in this, world of hyper competition and worrying about tenure and promotion. I'm an epidemiologist. I was doing community engaged research. Many of my colleagues were producing 30, 40 papers a year, analyzing very large, big data sets like that. And I'm, boots on the ground, sleeves rolled up, fighting the good fight to get zoning laws put in place and trying to get community engaged in the process. I had one project, and I'll say just something about it in a second. I worked on that for 6 or 7 years. It took 3 publications came out of that, but it was 6 or 7 years of like action-oriented and community-based building work to get that to move forward. It was transformative. It was actually called Transform Baltimore. How do you get that documented? How do you document that I was at the forefront of the single largest, policy that got implemented in the city to reduce violence in the city? If you're counting it up by publications, it doesn't look like I made that big of a difference. If you're counting it up by the number of reductions in gunshot victims or acts of community violence, then it was a huge success. So we've got to figure out how to reconcile, I think, these things. We also have to include and honor the valued voice of community. I'm very much nothing without us, about us without us. We produced this great publication in Progress in Community Health Partnerships. I've got the QR code for that here, really trying to understand what does that continuum look like. I always tell people there's not necessarily a wrong place to get involved in community engaged research. But what I would recommend to people, it's like with any relationship. Great relationships have trust. There's some time, there's good communication, there's clear sort of understanding of roles and responsibilities and all of that. So before I would move all the way up that continuum and do, community-driven or community-led or community-based participatory research, you might want to start off with things that are community-informed or community-partnered. But keep in mind these important contextual factors of all relationships. There's nothing worse than being in a relationship that's got academic partners, community partners, and the community partners don't feel that they're valued or that they're respected, when in fact, oftentimes they are the ones that hold the keys of knowledge and access to do the kind of work oftentimes that we like to do. And also these really important equity indicators. And you'll notice equity deals with things related to resources, power, control, influence, decision-making, and like that. So really great resource here for people who are interested in really a roadmap for understanding and assessing their own progress. Some other great examples around how to coordinate these, multidisciplinary public health responses and the real power of these community academic partnerships. I've highlighted a couple of things from Flint because I know most of these people. I trust this work. It's really good. It's really credible work. And I think many of you will find it very inspiring and maybe give you some ways to think about how to take your own research and move it more to kind of an action-oriented, community-partnered model. I'm going to skip through this. I do think this is an important note, and I'm acknowledging I have 2 more minutes left and I will be done in 2 minutes. The need for policy and action-oriented research. I gave the example of working on this work with Transform Baltimore. As we were building the case, right, we knew if we could get this critical piece of this legislation in and get some of these policy options activated in what was going to be the first zoning rewrite in the city of Baltimore in more than 40 years. And Baltimore's population reduced by half in that 40-year period. So if you can imagine land use and building use and all of that stuff changed, but the city didn't. I started to work with colleagues, with other students, with other stakeholders, with other community partners to build a case empirically for how we could use zoning. Once we got the law implemented, we then did an evaluation of it, and it has single-handedly been the largest strategy that reduced violence in Baltimore City in its history. So I do think there's a real opportunity for us, especially if we could align it with funding, to figure out how to do the kind of action-oriented research. And again, I wanted to go slow enough so you could get some of the QR codes, because there's really not enough time to sort of delve into them. And the last thing I'm going to leave you with is I think it's really important, and I talked a little bit about the action-oriented research, but it is about making things into policy. So I love to tell the story of the first time I baked a cake with my daughter, Olivia. She wanted to make it from scratch. We mixed everything up. We put the cake in the oven. We had a wall oven. She's standing, she's looking, she's watching the cake bake. And I look over and I see the big box of Domino's sugar on the counter, and it's unopened. And I realize we have baked the cake and we did not put the sugar in. And she says, "Mom, what's wrong?" I say, "Oh, we made a mistake. I think we have to start over." And she says, "Well, can't we just sprinkle some of the sugar on top?" And that's what I feel like we often try to do with policies. We're trying to sprinkle equity and things of the like on top of the cake, but we really have to accept that some of the systems and structures we have, and I think Dr. Nelson did a brilliant job of pointing to it, really have to be dismantled, and we have to do the work to get it baked in. And I'm going to stop there.
Fantastic. Well, I want to thank you both. First and foremost, really for your work and what you're doing to disseminate the important research you've done and the insights that you have. So thank you, and including thank you for doing that today with really inspiring talks. So again, I want to remind people to please submit questions if you'd like through the Q&A panel. And let me just get started then with some questions. I love the bake it in, and I also loved the idea, Dr. Nelson, around innovation in equitable contexts widen inequalities in health. And so I wondered if you could reflect a little bit more about that. I mean, I think it's such an important idea that if we don't address social determinants of health in our prevention and health promotion efforts, we really risk interventions that are less effective, interventions that are not sustainable or translatable, and we're really not getting at the fundamental causes of the inequities that we see. So could you both just talk a little bit more about this idea, like how addressing these more upstream social and economic drivers are so critical for more effective interventions and really for advancing health equity? Dr. Nelson, you want to start?
Sure. Thank you, Dr. Zink. I appreciate that question. I think that I'm an old public health person. I used to work in a public health department, and we always knew that these indicators we were looking at, I think for Healthy People 2020, that we were never going to get there if we had a segment of our population that was not coming along. We knew what the problems were, and all the great work we were going to be doing in the suburbs, and they were making these advances, that the overall number was not going to change if we were leaving so many people behind. And so the implications were beyond just the health of the people, but it had implications for the economy, it had implications for educational standards. And so it was important for us to know that as a community, we're not going to thrive unless we can get everybody healthy, which meant we understood that we have to look at these multiple level influences and also involve other people in health work, people who don't work in the health sector to be involved in health work. One of the comments asked about, tech and industry. I think that's important. In the example that I gave about PrEP, I think the scientists who are trying to figure out how to block an infection, but also be talking with business administrators to have to think about how we're going to pay for this, or how we're going to make this work in our clinic when we try to implement it, or insurers who have to figure out ways that they're going to determine whether or not they can cover the cost of these things. All that has an impact on whether or not these studies are going to lead to interventions that can be scaled and have equitable impact. So I think the appetite, I'm not sure right now if the funding appetite is there at some of our federal levels, because I think these studies are high risk. We haven't done them for 30 years, so we don't have 30 years of evidence to base them on. And that's sort of been the rule about how you sort of can move a study forward. And I think these are high risk, and it requires a different level of commitment to support this type of work. But I think that people out there who would try it if they thought they had a shot. And to Dr. Furr-Holden's comment, many scientists work in academic settings where you have to produce things. And so proposing studies that are likely to have impact but have very high risk is sort of disincentivized when you need to get a study funded to get promotion. So all these things kind of tie together. But I do think it is the way, and that's how I think it can help reduce some of these inequities.
Thank you, Dr. Nelson. Dr. Furr-Holden, what would you like to add?
Only one thing I would add to that is if we look, and depending on who you ask and what study you cite, it looks like healthcare is about 20% of the equation.
Mm.
Healthcare is about 20, and don't get me wrong, it's an important 20% because it's a 20% that's in our hands, right? So if we think about the rest of it then, and some people will say it's somewhere between 20 and 30%. Let's fall in the middle and say it's about a quarter of it. A quarter of it is healthcare. So then what are the other pieces? This idea around the social and political determinants. Well, those are in our hands theoretically, right? I can't sort of, and I've worked with lawmakers and policymakers, and I always tell students, be very clear, evidence is not equal policy. There are a lot of things that we know. We knew a lot about the harm of tobacco, but look what it took to get a simple warning label on the back of the box of cigarettes, right? Like, evidence does not drive policy. Policymakers drive policy. If you're lucky, you can use your evidence to influence a policymaker. So I just think it's important that the things, to go back to that example of the fence, if we start to deal with these systems and structures, they're self-perpetuating. I love the graphic that Dr. Nelson had, which showed this stuff is in motion. It's like real. Now, the problem is many of us are not trained to, we are disincentivized to, nor qualified to sort of bring that kind of activism to the work. So it really does go back to them. How do I have a say? Well, if you go upstream, funding priorities for the NIH definitely do drive the type of research that scholars like myself and Dr. Nelson can do. Who's in office and setting the budget and the priorities for NIH makes a difference. I think it's important that we start to look from where we sit upstream to figure out where we do have power and decision-making. Imagine if the Nurses Association got together and said, we're gonna advocate for this. You would be this mighty contingent, like a force to be reckoned with. But what is this? Something further upstream. Because a lot of what we do in our work is dealing with the downstream, I think, indicators.
And can I just add, I think what NINR is doing is important mainstreaming of these concepts, because I can tell you, and you probably know this, that there are people in universities across the country who would not even dare have this discussion that we just had today, because it seems so far out of the boundaries of what is considered sort of normal science. And I think the way in which NINR is leading and can disseminate this will help people figure out ways to readjust and go down these pathways that I just think we haven't done before. But I think that leadership will help scientists come along if they feel it's not a safe route, but in some ways, a safe route to go down. And NIH forecasting this through these lenses, I think, communicates that to people in an important way.
Thank you both. Okay, I'm gonna do a rapid fire 20-second, 30-second response, maybe if I can squeeze in two more. So to Dr. Furr-Holden, for social and political determinants, how would you discuss your points that poverty rate among Black kids had not been mitigated, despite that we have had legislators, representatives from the Black community? Are we missing a significant effort from our political leaders?
I think we are. I think we're trying to sprinkle it on top. You know, when we made that cake, we tried to cut it up, put it in with ice cream. We did try to sprinkle some powdered sugar on. It just was like, you can't. You can't have equity. We, the people, didn't include Black people, right? We baked our whole society without, fair, equal value on all human life. And now we're just trying to sprinkle sugar on top. So a lot does have to be dismantled, I think, and rebuilt.
Thank you. Okay, Dr. Nelson, let's wrap up with you. So when you speak about engaging people to support boots on the ground health disparities improvements, sounds like building strong community-based participatory research. How would you identify these individuals if they do not have a healthcare background? What skills might we want these individuals to have?
I'm not sure we want them to have any particular skills. I think that's part of the mistake that we make. We sort of professionalize people and we miss a lot of the local indigenous assets that exist in these communities who are surviving all the time, who could tell us what we need to do. I think you need to find people who are living the experiences that you're trying to change. That's the qualification. I think, and that's been my experience, and everything else can come along through capacity building. That's what I would say. That's the key ingredient.
Thank you. I can't believe how fast the hour went by. So I certainly want to thank both of you for the great presentations and the great discussion. We could go on and on, but I do have to wrap it up. So next slide, please. All right. As a reminder, continuing education credits are available. You can scan the QR code on this slide for a link to a survey to complete to receive your certificate. You can also provide, or we're going to provide a link in the chat. And when you leave the webinar, your browser should automatically open the survey. And we want to thank the Foundation for Advanced Education in the Sciences for their partnership around the webinar evaluations and continuing education. Next slide, please. Again, I am so appreciative to both of our speakers, Drs. Nelson and Furr-Holden. So grateful to you for sharing your knowledge and expertise with us. Thank you. And again, thank you everyone for joining us. We'll be announcing the date of our next webinar soon, and you can stay tuned on our website. So thank you so much, everyone, for joining us today. Goodbye.